Very welcome everyone. Today our topic of discussion is therapeutic plasma exchange and IVIG and immunomodulatory therapy. So this is a vast topic. I will try to complete as soon as possible. Next is starting from the beginning. We have to understand the concept of therapeutic plasmapheresis. So what is apheresis? Apheresis means taking away. So what we mean by therapeutic plasmapheresis? It means removal of patient's plasma and replacement with allogenic or autologous plasma. The main aim is to remove certain pathologic substance from the plasma that are responsible for disease process. So what are those pathologic substances? So these may be immunoglobulins, autoantibodies, lipoproteins, circulating immune complexes, and protein-bound substances and toxins. So there are certain diseases in which we use therapeutic plasma exchange, like hyperviscosity syndrome, Waldenström macroalbuminemia, multiple myeloma, and different autoantibodies mediated diseases like myasthenia gravis, GB syndrome, SLE, vasculitis, and etc. and so on. So there are four basic components of therapeutic plasma exchange. One is mechanism of therapeutic plasma exchange and prescription of therapeutic plasma exchange that we'll discuss in later part. And another is diagnostic workup before therapeutic plasma exchange and monitoring due to therapeutic plasma exchange. As you can see, we have to read the basic biochemistry, blood counts and coagulation profile and infection status before starting therapeutic plasma exchange. And we have to monitor regularly the biochemistry and blood counts and parameters. So regarding mechanism of therapeutic plasma exchange. So what are the methods of apheresis? So mainly there are two methods. One is membrane-based method and another is centrifugation method. So what is membrane-based method? Here the blood passed through hollow tubes made of synthetic membrane with relatively large pore size that allow passage of plasma, including plasma proteins, while retaining cellular components. And in centrifugation method, blood is separated by centrifugation into plasma and cellular components based on specific gravity. So there is a contrast between centrifuge and membrane apheresis procedures. That you can see that plasma extraction is quite higher in a centrifuge technique rather than membrane therapeutic plasma exchange. And common anticoagulation is used as citrate in centrifuge technique and in heparin in a membrane therapeutic plasma exchange technique. This is important for your exam purpose. So what is the target of therapeutic plasma exchange? The ideal target molecule is characteristics by identified etiology or toxic substance. It should be other molecular mass should be higher, more than 15 kilodalton. A slow rate of formation of that molecule and slow turnover and low volume of distribution. And another thing is central venous catheter is better than peripheral veins and common anticoagulation that citrate and heparin that we have already mentioned. Now, regarding exchange volumes, this is an important topic. How to estimate plasma volume? So, total body blood volume should be calculated first. Then, plasma volume should be calculated based on a hematocrit, and usually 1 to 1.5 times of plasma volume exchange per procedure is done. You can see that in case of 1.5 plasma volume exchange, you can remove around 80% of current plasma. Now, the question is, what are those replacement fluids? Commonly used replacement fluids are 5% albumin, saline, after the combination of both, and FFP. So there are certain advantage and disadvantage with each of the replacement fluids. Like there is lower risk of pathogen transmission and anaphylactic reaction in case of 5% albumin, but there is increased risk of coagulopathy. In saline, because of insufficient oncotic pressure, it causes edema and hypotension. The combination of albumin saline is commonly used, and FFP can also be used. Now, what is the dosage schedule of apheresis? So it's mainly depends on the nature of the target molecule. So in case of IgM, which is 75% intravascular, only 1-2 procedures usually required to reduce IgM level. For in case of IgG molecules, that is only 45% intravascular, and it's smaller in size. It requires more rigorous regime. So according to a standard recommendation, one exchange is done every second to third day. Exchange contains around 1 to 1.5 of plasma volume, and usually 3 to 5 procedures are needed. There are some exceptions also, like in Farz and TTP, almost daily or alternate day plasma exchange has been given. So American Society of Apheresis, there are 4 categories of indication of plasma apheresis. So category 1, where the apheresis is accepted as first line of therapy, either as primary and standalone treatment or in conjunction with other mode of treatment. In category 2, it's plasma exchange is the second line of therapy. And in category 3, the optimal role of apheresis is not established, and category 4, it is not indicated at all. So coming to the indications in details, what are those in category 1? TTP, sickle cell disease, myasthenia gravis, DB syndrome, alveolar hemorrhage. These are commonly used areas of therapeutic plasma exchange, and this falls into category 1. In category 2, we have this acute disseminated encephalomyelitis, cold agglutinin disease, cryoglobulinemia, Eaton-Lambert syndrome, and multiple sclerosis in case of acute attack. In category 3, we have acute liver failure, complex regional pain syndrome, and HLH and all that. So in this context, I want to add that in sepsis, there is no recommendation in sepsis, and according to certified sepsis guideline, it comes under category 3. So this is a wonderful slide depicting the role of therapeutic plasma exchange in different disease, and what are the pathological substances we commonly review. This slide is important for exam purpose. Coming next, the complications of therapeutic plasma exchange. It's maybe related to vascular access, related to anticoagulation. So these are common with other procedures commonly used in our ICU, and related to the procedure itself. It's a kind of renal replacement therapy. So we can have hypertension, bleeding, edema, loss of cellular elements, and hypersensitivity reactions. So coming to our next topic, what is role of intravenous immunoglobulin and immunomodulatory therapy? These are some newer areas in management of sepsis, and we have developed the concept of these newer therapies, because in sepsis that we all know it's associated with multiple dysfunction syndrome, multi-organ dysfunction syndrome, and septic shocks. It poses an overwhelming burden on worldwide healthcare and associated with a high mortality rate. It is a deleterious outcome of dysregulation of immune response and alteration of hemostasis. The inflammatory path in sepsis, what happens? The inflammatory pathway is activated. Pro-inflammatory mediators are released. Coagulation system is enhanced. Tribunal lysis is impaired, and complement mediated lymphopenia occurs. All of these events causes organ failure. The fine tuning between the pro-inflammatory and anti-inflammatory response is disrupted during sepsis development. So the basic concept is there has been a paradigm shift in the pathogenesis of sepsis. Okay. So there are some changes, like attention has been diverted from SARS to CARS, that is compensative anti-inflammatory response, which is also capable of bringing multiple organ dysfunction. The fine tuning between pro-inflammatory and anti-inflammatory response is disrupted during sepsis development. Cytokine storm is induced with excessive production of inflammatory chemokines such as interleukin 1, 6, TNF, alpha, etc. And then anti-inflammatory mechanisms comes to play. Apoptotic mediators induced with the attrition of CD4 and CD8 lymphocytes, dendritic cells, and beta cells, and activation of HLA here also regulated, and T cell and exhaustion. These are the basic concept behind the immune modulation in sepsis. So there, IVIG has a definitive role. The clinical rationale of IVIG therapy in sepsis lies in identification and neutralization of microbes and toxins, counter poisoning, the action of inflammatory mediators that I have already described, and the prevention of apoptosis of immune cells. So, the indications of IVIG. IVIG as replacement therapy. IVIG as replacement therapy, primary in primary immune deficiency disease, CLL, pediatric HIV and common variable immune deficiency. IVIG as hyperimmune therapy like post-exposure prophylaxis in different diseases. Now, this slide describes the role of IVIG as immunomodulatory therapy in different diseases like inflammatory disease, post-transplantation, hematologic disease, dermatologic disorder, neurovascular disorder. It's a quite busy slide that I can understand. So there are different aspects of IVIG administration. There are some dosage recommendations. These are not that much important for EDIC exam, I guess. And these are the adverse effects associated with IVIG. IVIG therapy may be associated with adverse effects like hyperviscosity syndrome, thromboembolic event, and acute renal failure. Acute renal failure occurs due to the stabilizers in IVIG patients. And there is increased, the risk of acute renal failure increases with diabetes mellitus and adverse volume depletion. Concomitant use of other nephrotoxic substance like aminoglycoside, antibiotics, and all. So, however, these adverse effects can be mostly avoided by adopting the proper measures. Renal failure as well as thromboembolic events may be prevented by adequately hydrating the patient. But remember, we have to hydrate the patient well when you are giving IVIG and slowing down the rate of infusion. So, after completing this IVIG, there are certain other aspects of immunomodulatory therapy and that I want to discuss. There are multiple researches that reveal that the patient with gram-negative sepsis has better outcome when treated with IgM enriched IVIG preparations. So, however, the immunoglobulins is reported to be highly effective for severe invasive gram-positive sepsis like streptococcal infection and streptococcal toxic syndrome and necrotizing fasciitis. Again, there are some lots of studies in which the benefit of mortality reduction was observed in septic post-cardiac surgery in patients with whom IVIG was used as adjunctive therapy. But non-occurring experience were noted in neutropenic patients with septic shock who didn't have any benefit from use of IgM-enriched IVIG therapy. So the use of immunoglobulin in sepsis is still highly controversial. So that's the take-home message, that the role is still controversial. There are certain gray areas, include doses, protocols, patient selection, lab parameters to be analyzed, and all that. There is no definitive guideline regarding initial dose, frequency, total amount, but also therapeutic target. Presently, the mainstay of sepsis therapy consists only early, appropriate, and adequate source control initial of prospective antibiotics and achievement of hemodynamic stabilization through judicious and optimum fluid and vasopressors. Despite the advancement in the development of novel therapeutic strategies, like I have already mentioned, therapeutic plasma exchange, like extracorporeal blood purification technique, newer antimicrobial focus, and immune modulation, yet there is no definitive intervention that translates to reduced mortality. So, surviving sepsis campaign guidelines have recommended against the use of IVIG in sepsis. This therapy is limited by comparatively high cost and variable availability. Next, about immunosuppressants, we have steroid, the most commonly used immunosuppressants. We have calcineurin inhibitors like cyclosporine, tacrolimus, mTOR inhibitors like sirolimus, eptrolimus, and antimetabolites like azathioprine, mycophenolate mofetil, cyclophosphamide. We have TNF alpha inhibitors, interleukin 1 inhibitors, interleukin 2 inhibitors. And among immune stimulants, we have vaccines, we have recombinant cytokines like interferons, interleukins, and all that. So, first coming to glucocorticoids. So, it is used in various autoimmune disease, transplant rejection, bowel disease, SLE, psoriasis, and all. There are multiple adverse effects of using glucocorticoids, even using in critical care area also for long dose and for long time. Among calcineurin inhibitors, there are cyclosporine and tacrolimus. These are the commonly used. But that I want to mention, these drugs are commonly used for prevention of organ rejection. And the role of these drugs in sepsis is under investigatory level till date. Again, we have mTOR inhibitors like sirolimus, eptrolimus. It is mainly used in prevention of acute graft rejection and restenosis of vessels and cancer treatment. Then we have azathioprine. It's a very old drug which inhibits the purine synthesis and interfering with nucleic acid metabolism and inhibit proliferation of leukocytes and lymphocytes. The use in glomerulonephritis, rheumatoid arthritis, systemic lupus, erythrocytosis, and Crohn's disease. Cyclophosphamide that we have already mentioned. And then there is the role of monoclonal antibodies. So these are mainly cytokine and cytokine receptor antagonists. We have TNF alpha, like etanercept. We have interleukin 1, 2, and 6 antagonist. That interleukin 6 antagonist tocilizumab is widely used in COVID times. We have rituximab, bevacizumab, cetuximab, and all that. IgG antibody therapy, it was kind of beneficial in some categories of patients in recent COVID-19 infection. Lastly, we have immunostimulants. So among immunostimulants, we get BCG vaccine and levamisole. So BCG vaccines, they stimulate T cell and NK cells. It is used in urinary bladder carcinoma. And what is levamisole? It restores the repressed immune function of B and T cells, monocytes and macrophages, but it can cause agranulocytosis. And it has been removed from market in 2005, sorry, because of agranulocytosis. And lastly, we have colony stimulating factors that recombinant cytokines that support proliferation of hematopoietic cells. We have GM-CSF and GCSF, like filgrastim, and thalidomide. Thalidomide, because of teratogenicity, it is again out of market. So these are the basic immune stimulants and immunomodulatory drugs. And again, I can understand this is a quite difficult topic, but questions may be asked around therapeutic plasma exchange and a role of IVIG, because this is a new developing management of sepsis and different illness in our ICUs. So with that, I think we are done with this presentation. So if you have any query, you can contact me. And I want to emphasize among therapeutic plasma exchange and different role of IVIG and the newer concept of sepsis that should be kept in your mind. However, further clinical research is needed. It's a needed of an hour to justify the use of immunoglobulins and establish the efficacy of interventions in the proper patient populations at the precise times and in optimum dose for the application. So with that, I want to close this session. Thank you.
Thank you, Dr. Mondal. It has been of really help for us. Thank you. So with